Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. And in this podcast, you'll hear from a diverse representation from our community. We want you to be both informed and inspired by their stories and experiences, and we're so glad that you've joined us today. This is Steve Caselli, and I'm the Director of the International Cardio-Oncology Society, and we are here at the American College of Cardiology meeting, the Cardio-Oncology section of ACC. And I'm here with my friend and colleague, Dr. Susan Dent, who is the president of ICOS. And we're speaking today with Dr. Darryl Leong from Hamilton, Ontario, Canada. And Darryl's going to tell us a little bit about his session here at the meeting. So, Susan?
Thank you. So Dr. Leong today at this meeting is going to be speaking about navigating genitourinary malignancies and in particular the cardiovascular complications. But maybe we could just start by elaborating on what do we really mean by a genitourinary malignancies? I think sometimes people think of it as just one disease, but it's really more than one disease, isn't it?
Yeah, absolutely. It actually probably comprises at least 3 diseases. The one that probably attracts the most attention is prostate cancer, simply because it's the most common. But cancers of the bladder and the kidney also are important conditions, and their treatments can have really important implications as far as cardiovascular issues go.
Thank you for clarifying that. When we think about those different types of genitourinary cancers, and those individuals are going to be exposed to different types of treatment, whether it be chemotherapy, radiation, targeted therapy, surgery may be involved, of course. Can you elaborate maybe on some of the cardiovascular complications that we see related to those treatments that patients receive? And of course, one that you mentioned that's very popular is prostate cancer. Maybe we could start with that.
Yeah, so prostate cancer obviously is the most common cancer affecting men. And the sorts of issues that we encounter are firstly that many men with prostate cancer have a high burden of cardiovascular risk factors and cardiovascular disease even to start with. Following that, a large proportion, as much as 40% perhaps, might at some point during their life course get treated with hormonal therapy. So it's called androgen deprivation therapy, to be a little more specific. And this is well known to exacerbate cardiovascular risk factors like obesity, diabetes, high blood pressure, and loss of strength. And so we feel that that's one way in which it can contribute to cardiovascular risk in this population. Now, coupled or added on to androgen deprivation therapy are the newer drugs, the androgen receptor pathway inhibitors. And these can have even additive or incremental cardiovascular side effects like high blood pressure, fluid retention, which increases the risk of heart failure. So I think for all these reasons, cardiovascular disease is a very important thing to consider in your patient with prostate cancer.
And what about the other sort of genitourinary cancers? You mentioned bladder cancers, or anything we need to be concerned about in that patient population?
Yeah, bladder cancers are really important for a couple of reasons. First, again, by nature of the demographic, people who tend to get bladder cancer often have a number of cardiovascular risk factors. And if they're getting treated surgically by cystectomy for their bladder cancer, it's a big operation. So I think the perioperative concerns in this population are really important. And, information can be gotten even at the time or before surgery about cardiovascular risk. All of these individuals will have screening imaging of their abdomen and pelvis, and certainly things like vascular calcification might be a marker of high perioperative risk in this population. The other concern in patients with bladder cancer as it pertains to cardiovascular disease is the need for anticoagulants and antithrombotic therapy, because bleeding is obviously an issue, and hematuria is an important complication of bladder cancers that intersects with cardiovascular care.
I think so. It's an important point you raised, that we often think, particularly in cardio-oncology, about dealing with toxicities that emerge from the treatment. What you were really emphasizing is the need to thinking about this very upfront at the beginning, and what are some of the risk factors that we can look at to try and prevent cardiovascular toxicity, not waiting until they develop a toxicity and then trying to fix the problem. Speaking along those lines, knowing that some of the treatments that are optimal for cancer care may cause or contribute to cardiovascular toxicity, how do we find that balance or approach the balance between the effectiveness of the cancer therapy and the risk of cardiovascular toxicity?
Yeah, it's a really difficult question. I think the very first step must include recognition. I think all too often, patients with genitourinary malignancies will go through the treatment process, and these issues won't have been identified. And then, if a major cardiovascular complication occurs, uh, it's a little bit challenging because you're trying to play catch up. So I think just awareness on the part of healthcare providers as well as patients through advocacy groups is an important first step. The second part of that is how do you balance treatment efficacy versus risk? And I think that's very much an individualized consideration. For example, for prostate cancer, where most of the side effects of hormonal therapy are really risk factor related, I think we can be effective at treating these and mitigating some of that risk. Whereas for other therapies, such as immunotherapy for advanced renal cell cancer, for instance, there the potential risks of complications like immune checkpoint inhibitor myocarditis are really serious and potentially lethal. And that alters the balance of risk benefit if they get a cardiovascular complication from these drugs.
I think that's important is that everyone's so different and, there are different treatments. There's different individuals have different underlying risks, may come to the treatment of their disease already with established cardiovascular disease. So it does really require a conversation with all the healthcare providers and that individual person. Are there any promising advancements in terms of risk assessment? We talked sort of about the importance of risk assessment and determining that upfront rather than waiting until someone develops a cardiovascular toxicity. But speaking around genitourinary, treatments and cancer, any work in that area that that you could elaborate on for us?
So one exciting piece of work that we hope to embark on and are seeking to develop is a risk prediction tool for non-prostate cancer-related death. Most of the in fact, all of the risk prediction tools that are commonly used in patients with prostate cancer really utilize prostate cancer characteristics. They're focused on bad prostate cancer outcomes, but actually the large majority of patients with non-metastatic prostate cancer will not die of the cancer. So we lack good tools to predict who those individuals are and what their risk factors for other causes of death, including cardiovascular disease, might be. So we're working on trying to develop those models in a large prospective cohort of patients with prostate cancer, and hopefully we'll have some more answers on that question in years to come.
Now, that's really exciting. I think the other group of patients that I think we have to start focusing on is those individuals living with cancer. And so we certainly know that even with metastatic prostate cancer, with some of the treatment options, individuals may live for years. So what about sort of managing those patients in terms of their cardiovascular health? I mean, I don't think it's a population that has really been looked at as much as those, with earlier stage disease. So what are your thoughts about that patient population?
I agree. Increasingly, for many cancers, and prostate cancer perhaps is the most archetypical, they become chronic diseases. And the hope is that patients can remain fit and healthy enough to benefit from future advances in therapy and almost, even if they've got, incurable disease, really move from one line of therapy to the next. To be able to do that, they need to maintain a certain degree of health. And if they are severely unwell for other reasons like cardiovascular disease, it can actually prevent them getting treatments for their cancer. And so we have this sort of vicious cycle of conditions conspiring really to end up with a poor outcome. So I think the more holistic we can be thinking about these other issues like cardiovascular disease, also physical frailty, and address them, then we can really help promote longevity and healthy lifespan in patients, even with advanced cancers.
Yeah, I agree. In fact, we're seeing emerging data to suggest that individuals, even with advanced disease, may die of cardiovascular disease rather than their cancer. And I don't think that message is always out there and very clear to patients and even healthcare providers. Where, as an oncologist, I'm always so focused on, treating the cancer and trying to, either cure patients or extend their life. But there's no value in extending life, if you're going to die of, or try to extend life if you're going to die of cardiovascular disease. So I think it's that looking at the combination and always thinking what are the implications of poor cardiovascular health in the patients that we're treating. Any last words? I mean, this has been a great conversation and as always, we look forward to your talk today, but any last words that you'd like to, that I haven't asked you, or questions?
No, I think, the last thing you said is absolutely right. If I were getting diagnosed with a cancer, my real focus as a patient, I imagine, would be on the cancer. How is it going to affect me? What treatments are needed? What's my prognosis from the cancer? But in certain instances, like you said, other issues, cardiovascular disease being really prominent, might actually be the hidden but big ticket and the big threat. And so, first of all, we need to recognize it and help identify those people where that's going to be the case. And secondly, figure out strategies to try and avoid that kind of bad outcome.
Great. Well, thank you very much for taking the time out of this conference to speak with us today.
Thanks so much.
For more information about ICOS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.